Good afternoon. My name is ANTONIA KAMATE Tukundane. I'm a nursing officer and I work at Mobile Hospice Mbarara as the site program manager. I'm delighted to be on this podcast to make a contribution towards amplifying pain management in Uganda. I'm glad to work with PICAO. Mobile Hospice Mbarara is a site of Hospice Africa Uganda, and Mobile Hospice Mbarara is situated in the southwestern part of Uganda. We have as our catchment area about 14 districts. We support people who are in need of palliative care. And many of our palliative care patients need pain management. Mobile Hospice Mbarara came to Mbarara in 1998 with a specific mission to help teach the students of Mbarara University about palliative care, and also to do the model of care which is mobile. We do home visiting, we do outreaches, we do roadside clinics. So starting in 1998, we had a brave nurse, Martha Rabon, who took a big step to come from Kampala and start a hospice in Mbarara. So Martha Raboni, together with Helen Iekat and Jackson Muchunguzi, made a great 3-man team to begin hospice in Mbarara. And at a certain point in time, when they had worked for some time in conjunction with Mbarara University, who gave us our first home. So the first offices of Hospice Mbarara were in Mbarara University, to be precise in the girls' hostel in the basement. And they worked there for some time. Eventually, we acquired this plot where we are now, and we started the services in this place. And the First Lady, Janet Museveni, came and opened officially our site. It was a great occasion. It was a big push for Hospice Mbarara. Since then, we have been serving in the southwestern region, providing palliative care for people of all kinds. Our biggest referrals come from the main regional referral hospital, but we also have some referrals from private facilities and also from health centers around the southwestern region. The interesting thing is that in the beginning, we used to have people coming from as far as Kisoro, Rubirizi, Isinjiro. We still have some people coming from that far. But because of our presence in Mbarara for the last 26 years, people have built capacity, and some people are able to be seen from their districts far off. But because Mbarara Regional Referral Hospital is a regional referral hospital, we still get some people from those places coming to us from the regional referral hospital. So Mobile Hospice Mbarara has been around for the last 26 years. We have worked with Mbarara Regional Referral Hospital. We've worked with Mbarara University of Science Technology, where we have been teaching palliative care and communication skills in the university in a bid to enhance palliative care from the time students are learning about medicine, about nursing. But in the field, we have been doing home visits. We've been doing outreaches to Ishaka Adventist Hospital. In Isinjiro, we go up to Chikagati Health Center 3, and we also work with Shunjezi Health Center 3 in Isinjiro, especially because we were targeting the refugee community. So we have really been privileged to help people over the years to get palliative care and pain management in particular. Mobile Hospice Mbarara being a site of Hospice Africa Uganda, we really can say that we are the born of the efforts of Dr. Anne Merriman, who is the founder of Hospice Africa Uganda. And because she is a doctor herself, she thought it was wise to come to a place close to the university so that we can be a resource for the university to learn about palliative care. That's why we have been teaching there palliative care and communication skills for a good number of years. And we still support them in many ways, providing a placement site for students to come and practice and also to do research. Palliative care, in simple terms, is care that is given to people who have conditions that do not respond to medical treatment, and they are chronic in nature. Many of the conditions that we look after, many of the patients that we support with in palliative care have pain. So in addition to providing palliative care in its totality, we also focus on pain management. So palliative care is a holistic care. It's not just about the physical body, a wound that you see or a tumor that you see. It is also about the social, the psychological, the spiritual well-being of the patient and the family. Because the family is not well when the patient is not well. And the patient is not well when the family is not. So we do not deal with each in isolation. We look at the patient and family, and that is key to our care. And very important, we do not separate the two. So the patient and family are the center of our care. So in a nutshell, we can say palliative care is a holistic care given to patients and family who are struggling with health-related suffering. And we support them through the whole journey of life. Mobile Hospice Mbarara supports a range of patients. Most of our patients are cancer patients, and most of them come in the late stages of the disease. However, we have had opportunities to catch people early in the disease process because they come sometimes just to ask, is this cancer? What is this I'm suffering from? So we counsel them, we prepare them to go to the hospital to get a proper checkup, and more often than not, we have been able to help them diagnose the disease early. However, most of them come late in the disease progression. We have also helped HIV patients, especially during those early years when the opportunistic infections were on the high. We helped so many people in the time of cryptococcal meningitis and this diarrhea that was not ceasing. We helped a lot of patients with HIV. Our HIV patients are still on program and they are doing well. Some we had to discharge them because their pain stopped. We also help patients with other chronic illnesses that are painful. There are not many, but we do have them on the program. People with arthritis of different kinds, we have helped them. So our range of patients are really around that. People with chronic illnesses. We've also helped patients with diabetes and have painful foot, the diabetic foot, we have helped them as well. So that is roughly the range of patients we have on Mobile Hospice Mbarara. Yes, we have different models of care. We have the outpatient clinic. This is where patients come to hospice. They are reviewed by the nurse and they are treated for their symptoms and pain and they go home. That is the outpatient model. We also have the home visit model where we go to the homes and visit the patient at home. The beauty about a home visit model is that we get an opportunity to meet the family, we get an opportunity to assess the home environment and to understand the social nature of the patient's life. We also get an opportunity to give health education, to teach the family some of the nursing tricks of how to handle their patient so that they are more independent and confident in managing their patient. We also have the outreach model where we go out to help patients who are from far away to get the care closer to them and they don't have to travel all the way up to Mbarara City. So we have two outreaches, one in Ishaka, which is in Bushenyi district. We stage at Ishaka Adventist Hospital, and another one in Isinjiro. We stop at two places, at Nshunjezi Health Center 3 and at Chikagati Health Center 3. But along the way, we do roadside clinics. We agree with patients on particular points where we can meet them, and then we stop and meet them there and give them their treatment and we manage them, and they can go home and we proceed to the outreach centers. We also have the hospital model where we visit Mbarara Regional Referral Hospital twice a week on the days for the cancer clinic. That is on Tuesdays and Thursdays. So we also have the hospital model where we do our care in the hospital. providing support, providing education, providing pain management solutions. So those are the models. We have the outreach, the outpatient, the home visits, and the roadside clinics. We have also done some significant work with the refugee community. We were supported by US Department of State to provide this care in the refugee community. The aim of that project was to help them start their own palliative care clinics, because the refugee communities are unique and it is easier when they have a clinic within the refugee community. So in Nachi Valley, Health Center 3, we were able to identify a nurse who we trained at hospice, and she was fully trained to be a morphine prescriber. And during her training, we also worked with PICAO to make sure that we accredited their center to have their own morphine. So they were able to work on things like having a double-locked cupboard for storage, and they had a doctor on site to support the palliative care training. And then the nurse that we had was also on site to provide the care, and we were able to help them start their own clinic. In Sunjezi, Health Center 3 is also a health center that supports refugees on the side of Oruchinga settlement. And we have identified a nurse there. She trained, and she's a morphine prescriber, and she supports the refugees who access care from Nshunjezi Health Center 3. So it was really a good experience. We trained community volunteer workers, we trained traditional healers, and we looked at also the spiritual leaders, and all together they got palliative care training. Through the support of the Department of State, we were able to get them 2 motorcycles and bicycles for all the volunteers, so that they could find it easier to reach out to the different people wherever they were to provide palliative care. And it was really a successful endeavor. We are glad that we were able to participate and contribute towards that. In our work as Mobile Hospice Mbarara, we have experienced situations where children are the caregivers of their sick parents, their sick uncles and aunties and grandparents. And when these people move on and pass on, these children are devastated. They do not see hope to be able to continue their education or to earn a living for themselves, because the breadwinner, the person they were depending on, has passed on. So we have been having the opportunity to support these child or young caregivers to be able to go back to school, or at least do something in a vocational training where they can use their skills to earn a living and look after their families. So together with PICAO, we have been able to support a few children and a few youth to go to school, to do something, to learn something, a skill like tailoring, like catering, maybe technical college where they could study skills like plumbing. And it helps them to have a future after the death of their loved ones. So we have had this opportunity to participate in the caregiver program, where we have controlled pain, not physical pain, but at least the social pain, and made life a bit easier together with the support of PICAO. That has been a great privilege for us. Personally, I think palliative care is a service that is so necessary in Uganda today. The number of cancer patients is increasing every single day. And the amount of pain, not only physical pain, but also social pain, is immense. I really feel like for palliative care in Uganda, we need to put our hands together and see how we can combine all resources to make it available to everybody. One of the things that I think would be a very big strategy is to identify more doctors to join the bandwagon. Nurses are already very many. We need more doctors to strengthen the team. Without the doctors, we are not able to achieve certain objectives. So I believe that we need to find a way to have more doctors on the palliative care programs, and together with the nurses, we can make a big, big difference. Another very important thing to note is that social workers are invaluable. At the moment, nurses are multitasking. They are doing their nursing roles and they're also acting as social workers. And if you understand that, you will see that it is not going to get the best out of the human resource we have. We need to have social workers to deal with social work issues and the nurses to deal with the nurses' issues. And that's why we need the doctors in the whole mix, because they also have a big role to play in terms of diagnosis and those technical things that they do. That would be my advice for the future.
My name is FRANCISCA NAGUJA. I'm a palliative care nurse at Hospice Africa Uganda, Mobile Hospice Mbara branch. And at the same time, I am a health services coordinator at Mobile Hospice Mbara. Among other things, we have the child caregivers. Child caregivers or a child caregiver is someone under 18 years old. And they do take up the responsibility of taking care of their parents or their loved ones who are very sick for a long time. And these child caregivers come about when the patient has no relatives, when a patient has children who are young, and when a patient is a widow or widower, and there is no any other social support surrounding these patients to take care of them. For example, in a village far away in Isinjilo, we had a lady who was divorced, and the eldest child fine was around 30 years, but there was a young girl who was around 15 years. And being that the first daughter was married off, she had to stay into her marital home. So this 15-year-old had to come in and step in to take care of the mother and the other siblings, as the other elder one looks for the money. And the responsibilities of this girl were basically to take care of the mother, bathe the mother, see that she has taken food, take care of the young ones, make sure that they have food, make sure that they bathe, make sure that they do go to school. And these cases are so many in the community. I chose this one because of the experience we went through as the health services providers, because there was a lot of psychological pain surrounding these children, that even the community kind of neglected them. We tried involving the father. The father was so much into the other family that he had gotten, and he totally neglected them. And as the health services providers, we have to come in at times once in a while, provide food, make sure that they have the necessities at home, and try to make a connection between them and the older sister who was trying to look for funds. And usually they miss school, and being that they do miss school, as an organization, we have a program called Give a Chance that tries to support these child caregivers to see that they go back to school. But because we have limited funds to support each and every one, the Palliative Care Association of Uganda chose us among the many in the Southwest, and we, through their program of Road Hope, to see that we can support these children not to lose hope, to make sure that they can see that there is light ahead of them, that regardless that they are taking care of their sick mother, they can see a future ahead of them. So through Road to Hope, we've seen at least some children going back to school, getting hands-on skills. Like we have one who never used to smile at all because of the routine responsibilities that she had to take care of the mother, lift her, take her here, clean her, every messy, clean the poo-poo, clean the urine. But right now, when she goes for the training, we see a smile again on her face. So it's wise to talk about palliative care in community through child caregivers. So the experience these child caregivers go through, usually they become an advocate for palliative care in the community because they have gone through a lot, they understand what they go through, and they end up being the counselors of fellow children who are going through the same experience. That's the first thing, and we always try and train them to be able to be an advocate for their fellow children, to see that they don't go through the same experience, or if they have gone through the same experience, to know how they can handle it and to know which people to contact and to know indeed which people to contact when they're in that kind of state. So we always take them through being compassionate as a component of palliative care, because if you're not compassionate, there is no way you can take care of the very sick. So, and being compassionate is not only to the patient themselves, their sick parents or sick guardians, but even to the fellow children in the community. And we believe that once you train a child from a grassroots, when they grow up, they'll always be the best caregivers to the very sick patient. So palliative care being the focus of taking care of a patient holistically, we tend to use these child caregivers to counsel their fellow children, the fellow age mates. So at times we use them when you go in the wards, that we identify one child caregiver and they come and talk even to the very sick, their fellow children who are sick, so that they also know that there is hope ahead of them, regardless that they are sick. And here at hospice, we usually have a daycare where we bring them on board and they share experiences and they talk to their fellow caregivers, because even a young can advise an adult. So when these adults who are scared see a child talking to them, they feel encouraged. If this child managed to go through this experience, I can still go through the same experience. So totally, they're really good advocates to their fellow children, not only those who are sick, but only even to those who are really giving care to their loved ones who are sick. So in palliative care, we deal with patient and the family, and each of us has a different role to play. First of all, me as a service provider, I have to make sure that my patient is as comfortable as we can, discuss the goal of care, because it's really important that we are all moving on the same line, on the same point, and assess my patient, know their needs, give them advice where necessary, try and solicit support from different sources. Of course, not necessarily giving them money, but help them within their boundaries, let me call them boundaries, to be sure that they can identify the support they need. And also try to advocate for them in the different organizations, because ideally we are supposed to work as a multidisciplinary team, but being that we are donor funders, we don't all have all that kind of team. So we have to look out from different organizations or facilities to be able to get these services providers that we need. I would take an example, like if my patient needs surgery, we'll talk through with the family and the patient themselves, discuss the purpose of this surgery. Why is it important at that moment? Because not all surgeries are curative. The surgeries that we call palliative, they're basically to improve on the quality of the patient. And then after, we have to identify where will this patient go that is affordable for them? Because I cannot send someone who lacks food at home to a private facility. No, I have to identify a hospital, government hospital that offers these services so that they're able to get them at an affordable price. And also, our role is to talk to the family members, take them through their roles, what exactly they're supposed to do, train them, give them some few nursing skills that they need at a moment, that if the patient is breathless, what are you supposed to do? If the patient has a wound, how are you supposed to clean it? Because when you're having these chronic illnesses, they tend to be costly. It's not mere looking at someone having an illness. It tends to be so costly for most of our families. And being that we are in a middle class, low middle class country, we tend to be so poor, I would say. It's in that kind of manner that services tend to be too expensive. So if I empower the caregiver to clean up a patient's wound, I'll have saved a lot. At least I'll have saved the money so that it can buy food, it can buy other necessities within the home. And then what is the role of a caregiver? A caregiver, here I'm looking at a child and an adult caregiver. They're basically to see that they implement what you've told them to do, that the patient is fed, the patient is cleaned up, the environment is safe for the patient, because usually we do advise them to always look back at what this patient used to live, the life of this patient. If this patient used to welcome visitors, at least they should allow visitors to come in. Or considering the situation of the patient, they have the power to say enough, like provide a visiting hours for this patient, like how they do in the hospital. And also, they are supposed to identify the needs of the patients, because they become an eye of a health worker in a home, because most of these patients are in a home. Because there are some patients who cannot talk for themselves and they're totally bedridden. So they're supposed to identify those small things that can bring out a quality of life or can help us give the quality of care for this patient. Take an example, the patient groaning at night. I may not know that, because even when we make home visits, some patients will show that they're fine, but because they have seen us psychologically. But when we move away, they may change, because maybe they're scared that we've moved away or something new has come up in. And they're supposed to be the voice of the patient, because usually being that we are in an African setting, the patient belongs to a community. And at times people come and give us different advices. So if this caregiver understands the situation of the patient, if she understands that this patient's illness is not going to get cured, or if he understands that this patient is supposed to go for chemotherapy, they become an advocate for these patients within the community. And the role of the family. In Africa, we are still lucky that we still have that family kind of connections. So the role of a family is basically to offer that support to the caregiver and to the patient. It's not necessary that you're supposed to be there 24 hours, no. Giving a caregiver a phone call, it means a lot. Giving a patient a phone call, it means a lot. Coming in and checking on them, it means a lot. It's not necessary that you're far away in Kampala and you're sending money. I'm not fine, you send the money, but these people need your presence there. So that support is really, really needed. And of course, I've talked about the money. The family has to see that at least there is some financial, of course, support for these patients. But we've gone into communities where families are totally disintegrated, and trying to connect them is really hard. And these are the patients who come to hospital seeking for care. They don't have money. They tell them do investigations, which are quite expensive, and it becomes a total mess. And just a patient going through that kind of experience can escalate the pain they're going through, even the physical pain, that controlling, giving them that quality of life can be really, really hard. So when everybody is on board, the health workers, the family, and the caregiver being there all the time, it helps us take care of this patient in a holistic way and giving them a good quality of life. So Palliative Care Association of Uganda is an umbrella association that joins all the palliative care services providers, and it's an advocate for us to say that the ministry or the government acknowledges the work we do, and also they're supposed to mentor us, because it's not easy offering these services to the community. And also they're supposed to give us those continuous I would call them continuous medical educations to the different palliative care services providers. And being that mobile hospice in Baraza offers is a palliative care specialty, that is our specialty basically. So we follow under them because they are like our bosses, and we are accountable to them whatever we do, and they have to supervise us. And usually they come in to give support, like I talked about the child caregivers. The support really they've given us to see that these children can have that light, can get the skills, can get hope, regardless of what they've gone through, means a lot, because our funding is kind of coming to an end, but we believe we have faith that they're going to continue helping us through supporting the child caregivers. So my final call is that palliative care is a human right, and each and every human being with a life-limiting illness should receive palliative care. And there are so many myths surrounding it, but being an expert, being a specialist, being someone who has worked in this field for over more than 10 years, I bring all this confidence to the world that the services are safe. They're about bringing comfort to the patient. They're about making sure that there is hope for each and every person. So this thing of saying that there is nothing we can do, in palliative care we say there is always something we can do to make sure that patients have good quality of life.